Bismillahirrahmanirrahim. Assalamu alaikum dear students. Today we are going to discuss different OSPE stations of GIT and renal system pathology. Before proceeding towards our first slide, that is of chronic ulcerative colitis, I have to show you some histological features diagrammatically on the preceding slides. So just have a look. Ulcerative colitis is characterized by a diffuse and continuous inflammatory process limited to mucosa and submucosa of colon. On microscopy, the normal colonic architecture is distorted. The crypts show atrophy, shortening, and loss, with many crypts appearing irregular and branched rather than straight one. Another important feature is the appearance of Paneth cell metaplasia, especially in the left colon, where these specialized cells are normally absent. In the lamina propria, there is a dense chronic inflammatory infiltrate consisting of lymphocytes and plasma cells extending to the base of mucosa, producing what we call as basal plasmacytosis. And remember, this is hallmark of ulcerative colitis. Neutrophils infiltrate the crypt epithelium, producing cryptitis, and when they accumulate within the glandular lumen, they form crypt abscesses. As the disease progresses, the mucosa shows areas of erosion and ulceration with overlying granulation tissue. Pseudopolyps may form as a result of regenerating mucosa adjacent to ulcerated areas. So let's have a look on the slide. This is slide of ulcerative colitis. You can see epithelium over here, which is not continuous, as it has been ulcerated at many places. Regarding the crypts, you can see there is branched crypt atrophy, and different size and shapes of crypts are there in this particular section. You can see chronic inflammatory infiltrate, which is consisting of plasma cells and lymphocytes. Paneth cell metaplasia will be appreciated in the basal area of these crypts. This slide is of colorectal carcinoma, which presents as adenocarcinoma arising from dysplastic epithelium. On microscopy, we see malignant glandular structures. You can appreciate over here different size and shapes of glandular structure all over this image. The glands are angulated back to back, lacking the normal spacing seen in benign glands. The glands show hyperchromatic nuclei. Just concentrate on that. Hyperchromatic nuclei. Hyperchromatic nuclei. The nuclear polarity is lost and the cytoplasm may contain mucin vacuoles, but on this image we cannot appreciate. Another important feature is desmoplastic stromal reaction. You can see over here, which has been denoted by stars, black ones. This is desmoplastic stromal reaction, the dense fibrous tissue surrounding and invading between malignant glands, giving the tumor its firm, gritty consistency on gross examination. Another slide of intestinal adenocarcinoma, that is colorectal carcinoma. Different malignant glands all over the image with hyperchromatic nuclei. Now this slide is showing you two different types of gastric carcinoma. Gastric carcinoma is broadly classified into two main histological types, intestinal and diffuse. First, we will discuss intestinal type. Here you can see malignant glandular structures all over the image. The nuclei are hyperchromatic, which is the hallmark of anaplasia, and anaplasia is hallmark of carcinoma. Desmoplastic stromal reaction, again, this fibrous tissue is invading and surrounding all the malignant glandular structures. Second type of gastric carcinoma is diffuse one, which is mainly composed of signet ring cells. These are the scattered cells having nucleus at periphery with abundant mucin in cytoplasm. You can appreciate abundant mucin, which is of eosinophilic nature, present inside the cells. Here you can also appreciate an intestinal type of gastric carcinoma. Some malignant glandular structures are filled with mucin. This one, and another, this gland. The lumen is filled with mucin. Another view of gastric carcinoma On left hand side you have intestinal variety, and on the right side you have signet ring cell variety. Okay students, now we move on to our next slide, that is of Ankylostoma duodenale. Ankylostoma duodenale is a hookworm, a nematode parasite that infects the small intestine of humans. The shape is all clear from this image. It has buccal capsule, intestine, testes, seminal vesicle, ejaculatory duct, spicules, and copulatory bursa. This is a male worm. The female worm has uterus filled with numerous eggs. In this slide, you can see Ankylostoma duodenale preserved in formalin jar. Now the parasite is Ascaris lumbricoides. Ascaris lumbricoides, again having male and female worm. It is the largest intestinal nematode of humans and is commonly called as roundworm. The male worm, its posterior end has this region is copulatory bursa with 2 copulatory spicules, and the female worm is elongated one and the posterior end is straight and blunt. So this is a picture of Ascaris lumbricoides preserved in formalin jar. We have another parasite known as Enterobius vermicularis, which is commonly known as pinworm or threadworm. It also resides in large intestine, especially the cecum and appendix. Again, we have male worm and female worm. You can see the difference regarding the structure, and again the male has copulatory spicules over here and the female has oviduct. This is formalin preserved Enterobius vermicularis lying in Museum of Pathology department. Now have a look on this slide. We have eggs of Enterobius vermicularis over here. They have a very special appearance which is important for lab diagnosis. They are asymmetrical. You can see one side is slightly flattened and the other one is convex. Similarly, like the alphabet D. This egg is filled with embryo or larva by the time it is laid. This is why the eggs become infective within a few hours, unlike many other worms. Because they are light in weight, the eggs can adhere to fingers, clothes, bedding, and dust particles, explaining why reinfection and family spread are so common. For diagnosis, we use cellophane tape test since they are deposited around the perianal region rather than being commonly found in stool. This slide is of egg of hookworm, that is Ankylostoma duodenale. These eggs are important for diagnosis because they have special features in fresh stool samples. You can see over here the egg is of oval shape, thin shell, segmented ovum, and clear space between the embryo and the shell. The diagnosis is egg of hookworm. Now this slide is of Wilms tumor, nephroblastoma. It is the most common malignant renal tumor of childhood, presenting between the ages of 2 and 5 years. You can see we have 3 components on histological section of Wilms tumor: blastemal, epithelial, and mesenchymal. In blastemal component, we have sheets of small blue round cells. This is very important. We have many tumors having round blue cells, and they are grouped together under the heading of round blue cell tumors, and this is a very important viva question both at undergraduate and postgraduate level. In epithelial component, we have primitive forms of tubules and glomeruli, abortive tubules and abortive glomeruli. In mesenchymal component, we have fibroblastic proliferation all over the tissue. The pink one, the fibrous one, mesenchymal component. You can see over here again round blue cell tumor infiltration. These round blue cells are hyperchromatic nuclei, hyperproliferative epithelia, nuclear atypia, that is nuclear pleomorphism, all are hallmark of anaplasia, which is characteristic of any malignant neoplasm. So, another view of Wilms tumor, round blue cell tumors, desmoplastic reaction, and the primitive glomeruli and tubules. Together they form pediatric renal malignancy with triphasic histology known as Wilms tumor or nephroblastoma. Now we are having a slide showing 4 different histological varieties of renal cell carcinoma. Renal cell carcinoma is malignant one having 4 histological variants: clear cell, papillary renal cell, chromophobe, and collecting duct carcinoma. In clear cell, we have cells with clear cytoplasm because of being rich in glycogen and lipids. In papillary histological variant, we have papillary structures. You can see over here the branching ones, the branching pattern, papillae formation. This is papillary variant of renal cell carcinoma, having foamy macrophages and samoma bodies. In chromophobe variant, we have pale cells with demarcated borders but a nucleus with perinuclear halo. It means there is an area of clearing around nuclei, perinuclear halo for chromophobe renal cell carcinoma. In this rare variant of renal cell carcinoma known as collecting duct carcinoma, we have irregular tubules in desmoplastic stroma. You can appreciate over here eosinophilic bands of fibrous tissue, that is desmoplastic stroma. Another slide for comparative view of clear cell, papillary cell, and chromophobe. These are 3 common variants of renal cell carcinoma. You can appreciate clear cells, papillary pattern, and the cells with clear perinuclear halo, the area of clearing around nuclei. This slide is of post-streptococcal glomerulonephritis, a disease which occurs 1 to 3 weeks after group A beta hemolytic streptococcal skin infection or pharyngitis. You can appreciate over here enlarged glomeruli with neutrophilic infiltrate showing acute infection. Here we can have a comparative analysis of normal light microscopy and immunofluorescence microscopy images. In the normal one, you can see the glomeruli over here. In PSGN, the glomeruli is hypercellular with neutrophilic infiltrate. On immunofluorescence microscopy, the immune deposits consisting of antigen-antibody complexes are shown here by immunofluorescent deposits. Dear students, now we are having a slide of benign prostatic hyperplasia, which is a very common condition in elderly men resulting from androgen-driven hyperplasia of both stromal and glandular components of the prostate in periurethral zone. Microscopically, the features are very prominent: hyperplastic glands of variable sizes. Some glands have papillary infoldings. Glands are lined by double layered epithelium. Inner is columnar and outer is cuboidal. The glandular lumina are filled by proteinaceous secretions known as corpora mylesia, and this eosinophilic tissue is known as fibromuscular stroma, which is spread all over the tissue between the glands and surrounding the glands. So this is another slide of benign prostatic hyperplasia. These are the proliferating prostatic glands, this proteinaceous secretion corpora mylesia, and the fibromuscular stroma. Another slide. Glands lined by double layered epithelium. You can see over here inner columnar and outer cuboidal, and again corpora mylesia. Now this slide is of carcinoma prostate. It is the most common cancer in men, usually rising in the peripheral zone of prostate. So a typical adenocarcinoma picture over here. You can see small, overcrowded, infiltrative glands showing the signs of malignancy with nuclear atypia, hyperchromatic nuclei, prominent nucleoli, and increased mitotic activity. If you can compare it with the benign ones, you can see the benign glands have properly defined lumen, double layered epithelium, and the nuclei are not showing the sign of atypia. But in malignant glands, they are tortuous, the lumen is getting obliterated, and nuclei are hyperchromatic. The diagnosis is prostatic carcinoma. This is detected by raised serum PSA levels, prostatic specific antigen levels. This is your Viva question related to this slide. You all must know about it. Thank you very much and best of luck for your upcoming exams.